I have nothing to disclose, sadly, no winning Powerball tickets or Mega Millions. I will, however, acknowledge two biases up front. I spend a lot of my time in the ICU, and I spend a lot of my time really admiring the appropriate use of ultrasound in a very focused setting, and so that's going to sort of play into how we should monitor our trauma patients, and I'm going to speak to two areas, really in the resuscitation area and in the ICU. So what is the evidence for using what sort of monitoring in the trauma bay, and should we even think about monitoring? And what should I do in the ICU? And I'll focus my comments on three areas. Are non-invasive monitors sort of successful? I don't know if those of you in the audience who use the Vigileo or FlowTrack system, is that efficacious? Should I still be using central venous pressure monitoring and PA catheter monitoring? Sadly, that's still very used frequently in my institution. And what is the data for echo in that setting? So I don't know of those of you who remember these days of trauma where every patient was like this. So a hypotensive patient came into your trauma bay after a motor vehicle crash, and it was a very simple question you asked yourself: why is he hypotensive, and how should I monitor him? And I will say that it really didn't take much of a rocket scientist mentality of this. It certainly probably didn't take much of a monitor either, acknowledging that FAST certainly played a small role here, because your questions were simple. Is he bleeding? Where? Did it stop? And if not, where's the best place to fix it? Do I need to be in the operating room? Do I need to be in IR? Do I need to be in my wonderful hybrid room? And I would say that anything that you did on that patient to slow down that train moving you to the appropriate tract of identifying bleeding and stopping it, short of providing access and I would say egress out of the ED, is totally wasting time. And I think that was really for years what our trauma bays look like. And I will say that as a proponent of ultrasound, that really doing anything to slow down that train was a bad thing. The old days. So here's your new reality, right? A hypotensive patient presents to your trauma bay now after a motor vehicle crash. And you have to ask yourself now more frequently, why is she hypotensive? And how should I monitor her? And of course, grandma crashed her car on her trip back from the hemodialysis center, on her Xarelta and Plavix and aspirin and et cetera, et cetera, et cetera, right? This is sadly our new reality. And so I would argue that maybe it is going to take a rocket scientist, and certainly it may even take a fancy schmancy monitor, because you have to ask yourself, is she bleeding? And is the bleeding surgical, or is it from whatever the latest poison is on this patient? Is she hypovolemic? You know, did grandma just come from her hemodialysis appointment? And I can't count the number of patients I've had on their way back crashing from the dialysis center. Did they just finish their chemotherapy and they've been vomiting? Is grandma septic? Why did she crash? Is there sort of a cardiogenic component to this? Did she have her heart attack before the crash happened? Was she experiencing some form of distributary shock from liver failure, from medication changes or overdoses, as our patients are? And so in this setting, there actually now may be a benefit to monitoring your patients. So how do we do that sanely? So I think regardless of where you are, you should ask yourself these questions with a monitor. What do we want to know? What do we want to fix? And is doing this going to change things? What are the things we want to change? I think mortality, morbidity, and certainly whatever we do, we should make the care more efficient. So once we rule out the standard trauma bay bleeding, however it is we do that, I think there may be a role for asking these two questions. Is the volume status adequate? And is there any issue in the patient's contractility, or is there an issue with vascular tone? And once again, focused, quick, in and out. So I think that in these sort of new patients, these newfangled patients, we may have a question to ask and answer. It should be answered quickly, one time, and therefore I think the way you should look at these monitors is as a qualitative question, and possible, if possible, visually. Because This, I think, is a different strategy, what I'm going to show you briefly in the ICU, where I think there actually is a need for quantitative data and repeatability, because we're going to titrate our data to this. Because still at the end of the day, I think your job in the emergency department, in the resuscitation bay, or the trauma bay, is to get the heck out of there and get to where you need to go. It may just not be the operating room in these new patients. So is there a tool that I can do this with? And yes, obviously, from the ultrasound geek that I am, and you already have it in the trauma bay. So how can you use this tool in the trauma bay to very quickly answer these questions? So you may or may not have heard of the concept of looking at the IVC's size and compressibility. You already look at this view when you do a FAST, or at least we used to do this view when we looked at a FAST, when we did a long axis subxiphoid view. Somewhere over the last decade, we've flipped the probe 90 degrees and we no longer get that. But if you turn your probe back to the way we did it when the exam was described in 1992, you actually do see your cava. We can measure the collapsibility of this on respiration. You take a deep breath in and this thing collapses. There's a suggestion of hypovolemia. And surely if you have a small cava and it collapses, your patient is likely going to respond to fluid. And a hypotensive patient with these features should be given fluid, and certainly if that patient is bleeding, you should give them blood. So what exactly do I mean? This is a long axis view of the cava. On the left, marked IVC. You see that going into to the right atrium. And on the right, you actually see a very small cava going into the heart, and this is a feature of someone who is hypovolemic. And if I could actually get some help sort of firing up these videos over here. Okay, there we go. Let's see. There we go. So on the left, you see, if you fire that one up again, a cava that completely collapses with the patient taking in a deep breath. If that patient were hypotensive, a little bit of fluid wouldn't do them harm. In contrast, let's look at the one on the right. Big fat cava. Taking a deep breath, if you'd cycle it again, not a darn thing happening. So if this patient's hypotensive, fluid's probably not going to be the answer to that question. All right. And if you have to have a number of this, there's many algorithms built on these, but the suggestion is that if you collapse your cava and it's smaller than 2 centimeters, your CVP is less than 5. And then the other thing you can potentially do in the trauma bay with your ultrasound now turned echo is to get a visual estimation of ejection fraction just by eyeballing it. It's actually pretty darn easy, and there's probably no role to get any fancier than just looking at it. And so I'm going to show you these in a minute. So what's important to look at these when you look at the heart is that you want to look at coordinated contraction where the ventricles come together rather than just sort of jabbering around. Sort of the difference between Miley Cyrus's version of dancing and, I don't know, Dame Margot Fontaine. For the younger people in the audience, Google it. You'll know what I mean. Okay, so if we look at the one on the left, this is a normal heart beating. If you'd fire that one up for me. Without knowing a darn thing about echo, if you could cycle again, that heart's beating pretty well. The ventricles come together kind of nicely. So if your patient were hypotensive and they have that, I would say that they're not having a heart attack. Okay, not knowing a darn thing about echo, if you do, let's look at this middle one. This is a very sad heart. That's not moving well at all. That was me when my alarm clock went off this morning. Okay. And then on the other hand, if you look at this top right one, this might be someone who is just so hypovolemic, they're doing everything they can to get this heart moving. And you would have your answer pretty darn quickly, and I wouldn't slow down the trauma bay, which is, I think, important. Okay. So the real question is, does it improve outcome? All right, I'll give you this. We don't know, and the data certainly isn't there. It can change therapy. A hypotensive patient with normal volume status and a depressed function may in fact benefit from an inotrope, and a hypotensive patient with normal volume status and cardiac function may in fact benefit from a vasopressor. For example, a patient with a spinal cord injury, for example, you might see that pattern in. So are there data? There is, in fact, an ongoing study out of the University of California, San Diego, looking at, and they're still enrolling patients, what is going to be the role of looking at caval assessment and early detection of bleeding. And that data will be forthcoming. And then, one of the big proponents of this from Eastern Virginia, from Richmond, looking at the use of this limited study in a randomized trial of 240 patients, in fact showed that, interestingly, this view, at least one view, doable in all, although acknowledged 40% of the patients did have at least one of those views be poor. And the patients who underwent echo, were randomized to echo, got less fluids and went to the operating room faster. So at least in this study suggested that it may matter. But let me now go to the ICU, where I think it's really got a bigger and a different role. So once again, what do we want to know? I think we want to know whether the patient is dry, vasodilated, cardiogenic. What do we want to fix? And back to the standard 3 questions. Does it change mortality, morbidity, and does it make care more efficient? I think all of the latter things way more important in an ICU setting than it is sort of in a trauma bay. So more specifically, I think we want to know, is cardiac contractility adequate? Does a septic patient require fluids or pressors? Does the exsanguinated patient require fluids or pressors or both? And does my patient who has both renal failure and impending renal failure with cardiac and pulmonary issues have adequate preload? And do I need a monitor at all, or can I figure that out clinically? So what do we want to know? I think we want a dynamic assessment of volume status. And let me quickly explain the quantitative exam with ejection fraction and stroke volume measures. Acknowledge that this is a different strategy from the emergency department, where we're merely asking a very simple focused question. I think in the ICU, we want to not only ask that question, but we want to answer in a way to give us data to drive an algorithm. And I'm going to sort of suggest to you that echo may be a really good way to do this. So first of all, what do other groups say about the need to hemodynamically monitor our patients, be they trauma or acute care surgery patients in the ICU? So a very nice consensus conference that sort of brought together all the leaders in critical care about 6 years ago, and they used grade methodology to come up with recommendations. So for example, should we even monitor CVPs and fluid responsiveness in shock? 1B recommendation, so pretty high grade of evidence. No, really CVP readings are pretty useless in these patients, and rather what they recommend is looking to see whether patients respond to a fluid challenge, i.e. fluid responsiveness, with or without data showing you that it did affect things. Very nice studies from a medical intensivist, Paul Merrick, showing that CVP is pretty useless, that static measures do not respond fluid responsiveness, that the correlation coefficient between CVP and actual blood volume measures measured in a very scientific way, worse than the flip of a coin, 0.16. So, really the CVP is pretty useless in determining what our patient's volume status is. What about non-invasive measures? And this is the protocol card from the FlowTrack Vigileo system that Edwards manufactures, and once again, I don't have any funding from them. I just sort of tell you that this is out there. This allows you to measure using a standard femoral or radial arterial catheter without frequent calibration to come up with a volume assessment by looking at a feature called stroke volume variation, or the difference under the curve of what the arterial line looks like, and sure enough, it correlates very well with what the patient's volume status is. But should we monitor cardiac output? Once again, the consensus conference says no. Rather that they recommend frequent measurements of standard vital signs, and they don't recommend a routine use of a PA catheter. In fact, the Cochrane Collaborative, looking at this issue this very year, looked at the 13 randomized controlled trials on PA catheters and said, in fact, that there really is absolutely no benefit to using them in terms of mortality, length of stay, and cost. So we should abandon the use of PA catheters. So what about echo? Well, the group says that maybe this is going to be a monitor that sort of helps us out. I think further, sort of to suggest it versus a PA catheter, PA catheters really take a very complex problem and really reduce it to a single number. And they really provide a very simplistic conceptualization of our system. It treats the number, it leaves us sort of standing outside of the room wondering what to do. And I would argue that echo gives us a couple things that are a lot more beneficial. So first of all, just like that IVC collapsibility, it really gives you both static and dynamic assessments of volume status. There are other more sophisticated methods in echo that we can do that as well with. Not only can you look at the left heart, but you can look at the right heart as well. And since that's the thing that's sort of right underneath the steering wheel, I think that's a very, very helpful measure to have in trauma patients. And it certainly takes all of these things and puts it together in a nice exam that in the setting of ACLS or rule out PE, tamponade, all the crazy things our injured and ill patients do in the ICU can help us in terms of wall motion abnormality and valvular defects, pulmonary physiology as well, or pathology. So let me just end with this sort of quick concept on what echo can do that PA catheters can't. So PA catheters really equate cardiac function with cardiac output, and they confuse RV and LV function, and that's really sort of a difficult problem. So the preload data that they give us is very questionable, and they give us the number of CVP of 8 or a wedge of 10, and certainly, as we know, they can be affected by things other than volume status. So as we say, cardiac output really doesn't give you a measure of function. It's often confused. It really is a measure of work and delivery, and let me give you an example. So say in a patient whose stroke volume is 50, sort of borderline normal, whose heart rate is 90, and whose index is 2.2, all borderline normal, well, if I could give you a monitor and tell you that the patient's ejection fraction was 20 or very low, well, you would give them a completely different therapy than someone whose ejection fraction was very high. And echo can give you both ejection fraction and stroke volume. So ejection fraction, a measure of function, not delivery. For example, someone's EF can be very high, but depending on what their stroke volume is, you might either give them fluids or do absolutely nothing. So if you have both of those components of your data, life is going to be good. I sort of borrow this from a former colleague of mine, but here's sort of the example. Let's say, in my world, you're on the LA freeway and you're trying to sort of merge onto the lane. And you're either in car at the top left, the gorgeous Porsche, or you're in that thing in the bottom right, which looks a lot closer to my car. So you're traveling at 40 miles an hour. Your cardiac output is 40. You wish to get to 65. You want to get your cardiac output normal. Which one would you rather be driving, right? Would you rather be driving the Porsche or the VW? And obviously their numbers are the same, but that's the difference between cardiac output and ejection fraction. And it is, in fact, what an echo can do for you that a PA catheter can't. So my colleague has a very nice algorithm card that suggests, based on which little echo category that they're in, whether they need pressors, fluids, nothing, or inotropes. There are many versions of this exam. This is one of the European versions of it that sort of give you this. They all have cute little names. I'm guilty for one of those cute little names. This is the beat exam that Dr. Fries from here as well participated with us as well when we were in Texas. And this is an exam that gives you focus data to determine whether your patient needs fluids, pressors, or inotropes. And then this is the study from the University of Maryland suggesting that it was very successful in doing this in injured patients and in ill patients, and they got their data much of the time and could change therapy. So in conclusion, in the trauma bay, I think that there still are old school patients out there. They really only need a rapid search for bleeding so you can fix it. So when someone tries to come into the trauma bay with an ultrasound machine with someone who's hypotensive with a gunshot wound to the abdomen, shoo them away. It's still appropriate. But there are now a new wave of patients who may benefit from a rapid quantitative echo, underline rapid, to evaluate contractility and volume status if you can't figure out why they're hypotensive. And the ICU acknowledged that no monitor has been demonstrated to improve outcome, and echo, sadly, is one of those. If, however, you feel compelled to get more data, some sort of a dynamic volume assessment, either with that Vigileo or an echo, and an ejection fraction assessment with echo is going to be beneficial to you. Thank you very much, and I appreciate the opportunity to speak here.